Well, we're going to go ahead and get started. I'd like to welcome everyone to the ABIN monthly webinar. We are so grateful that you're here with us this morning. A couple of housekeeping issues. We would like you to know that this webinar is being recorded. If you do stay on this call, you're granting us permission to record you, and we do post these webinars to our website. We're going to ask that you stay on mute and mute yourself so everyone can hear the presentation. If you have questions, please type them in the chat or come off mute, and we will be monitoring the chat and making sure we answer your questions. And with that, I'm going to ask Dr. Gibson to introduce our speaker today, Dr. Raney.
Yes, Lori, Dr. Raney, I'm glad I've gotten here. I just came from another meeting, and but I really wanted to get here in time to introduce Dr. Raney to you all, because I've gotten to know her virtually and in person at meetings over the last several years, as I have personally been doing more work in the integrated behavioral health arena. And, you know, Dr. Raney is known as being one of the national experts that have to do with integrated behavioral health, not only in collaborative care model, but also in the other types of models. She understands models, programs, and she's a rare psychiatrist, I will say, in that she not only has research and is very focused on knowing the evidence. And frequently when you ask her a question, she'll say something about, well, there's not really evidence about that, or she will quote a study. And so whenever we're trying to teach best practices, I really think that's important. But the other thing that Dr. Raney is good at is she does this work. She has been the psychiatrist working with patients in integrated care, working as part of a team with behavioral health consultants of all types. And then she's an excellent speaker. And even last week, we had a fantastic presentation that she was facilitating with the CFHA Collaborative Care Management Special Interest Group. And I'll just throw that out there. If anybody, CFHA has some great resources, and that's been one. But Dr. Raney led a conversation about how psychiatrists do case reviews in collaborative care management. But this talk, very much happy to hear about the new comprehensive healthcare integration framework, and how this can bring us to the next level of integrated behavioral health. So that's probably not a great introduction, except Dr. Raney, I'm so glad that you're here and that you can bring your expertise to the state, and especially bring us up to date with what's the latest in the evidence and best practices related to integrated behavioral health.
Great, thank you, Dr. Gibson, and glad to be here this morning. If we can pull up the slide deck, that would be great. You guys have that?
Yes, I made you co-host. Are you able to share?
Share my screen?
Yes, you should be able to share.
Okay.
Let's see.
Let me do that. Sometimes when I get in there and share, I can't monitor the chat box.
I am happy to share if that would be easier. Let's see.
Do you have it? Did you get the copy I sent this morning?
Yes, I do.
If you share, and then if you give me the power to switch the slides, then I can stay.
Oh.
I can watch the chat box. I've learned with this you can't do both. You
Okay.
do one or the other, but not both. Yeah.
Let's see if I can figure this out.
And also, I'm way out here in rural Colorado, so sometimes I get a little lag, and so it lets me keep talking. There we go.
Let's see. How's that?
Yep. And then
Great.
Can you turn over the slide change?
I can I'm not sure how to do that. Let's see.
Okay, that's okay. I'll just say next slide.
Okay.
I just in the bottom left. There's typically I can just switch slides, but that's okay. I want us to get going and not lose a lot of time. So again, thank you for inviting me nice and early here on Mountain Time to join you guys today to talk about a project that I've been working with the National Council for over a year. And sometimes I've lost track, a year and a half. Patty, I don't know when the Medical Directors Institute of the National Council came up with this bright idea, but it has certainly been a labor of love. And so what we're going to talk about, as Dr. Gibson mentioned, is the Comprehensive Healthcare Integration Framework. We affectionately call it the CHI, and I'm hearing around the country, Washington State Medicaid is adopting the CHI, so-and-so is adopting the CHI. So this is our vital life energy, we hope, for integrated care. There you go. Is to have some guidance to folks about integrated care, and we're going to talk a little bit about why, and much of this is going to resonate with what you guys have experienced. So the development team, again, this is a project of the National Council, and many of these slides are from the presentations we've been doing around the country about the CHI. It started, we have a group within the National Council called the Medical Directors Institute. It's a whole lot of psychiatrists who have been or are medical directors of community mental health centers in general, but we have a lot of other people that have joined the group. That group, we have a subgroup of that, and then we brought in an expert panel. We wanted payers, we wanted policymakers, we wanted all kinds of stuff. We brought people in for the NIMH, we brought people in from CFHA that Dr. Gibson just mentioned, the American Psychiatric Association, the American Psychology Association. We brought all kinds of stakeholders in because we really wanted kind of a broad buy-in and acceptance, because we know in the field how people can get a little protective or a little gildish on some things, and which has hurt integrated care, as some of you may know. And so we really wanted to get a large stakeholder group. And then 4 of us committed to our lifetime, a good chunk of our lives, to actually being the co-editors of the paper, which meant regular meeting, writing, rewriting, editing, arguing over what goes, what doesn't, sending it back out to the expert panel. They commented, we redid it. It has just been crazy. But this is the development team and how it went within the National Council, just so that you guys know this wasn't kind of a one-off. So where are we right now? This is what we were just talking about. Where are we right now? Okay, so we have some knowledge around bidirectional integration. We've actually got about 20, 30 years of trying to do integrated care. So this isn't something that popped up in 2006 or 2010. Back in the 90s, when Hillary Clinton was trying to get the health care piece going during Bill Clinton's presidency, a bunch of psychologists and primary care providers got together and said, hey, I wonder if we can work together and have something that's happening in this new thing that we're putting together. And of course, that went to the wayside. But these conversations have been going for quite a while. So we've got, since that time, a steady growth in knowledge around integrated care. We started off with kind of the 4-quadrant model, the Doherty 3 levels of integration. The SAMHSA 6 levels is something that is kind of prominent in the field right now. The iPad is a tool of the SAMHSA 6 level. So we've kind of had these basic conceptualizations. They fall short in a number of ways. They're just conceptualizations. They aren't actually based on research. They're just based on ideas and thoughts about what this could be. We have specific models. We have collaborative care, Dr. Gibson mentioned. We have patient-centered medical homes. We have now the CCBHCs. I'm guessing you guys have those in Arkansas. So models have popped up, but again, without a framework. We've also had, again, the research, so what's best practice. As all of this has been going on, people have been trying to do research. What makes collaborative care work? What makes is patient-centered medical home really effective? There's been research happening, and then there is evidence that demonstrates improved clinical outcomes, and particularly in something that Patty and I have been participating in, especially with CFHA, but in particular with the collaborative care model, which has now over 100 peer-reviewed, randomized controlled trials. So all of this has been happening over the past 20 to 30 years. But in spite of all that, I don't know how many of you have had any trouble implementing integrated care. So, all of that, and here we are, right? So here we sit with these barriers, lack of flexibility in implementation. There's states where you can't even have a behavioral health and primary care visit on the same day. I mean, California, huge state. You cannot hand off a patient to a BHC and expect to get paid. It just still blows my mind. They did a study. It's going to cost them $2 billion. I don't know what it cost them to not do that and for patients to miss out on an opportunity for behavioral health intervention in primary care, but that's what they did. Did a study, can't do this, we're not going to allow same-day visits. I mean, just the things that go on just blow my mind sometimes. We don't really have appropriate ways of measuring progress in integratedness. To say you're a 5 on the SAMHSA 6 levels, in my mind, doesn't mean anything. It's a pretty meaningless. You kind of took a shot with a dart at those 6 levels and said, I think I fit here. So we just really don't have that, and and because of that, I think we don't have a way to connect our integrated care to true value. And our payers really want to see value, right? They want to see value. They want to find, providers, surgeons who have a lower infection rates. They want to find integrated care programs that actually demonstrate people get better. And there are models of integrated care that really don't have outcome measures because there may be one touch and a belief that one touch across a larger population has value when it's really hard to demonstrate that. It's in your head, it's a conceptualization that works, but payers really and policymakers really want to see value. And so because we don't have value, we don't have financing support. We still cannot convince our payers. It took the longest time, even with collaborative care, where we actually had that value to come up with those collaborative care codes, which is at least something start in what we call a case rate or bundled payment to actually pay for integration. So in spite of all these years, 30 years in, this is where we're kind of stuck. So we needed something like the CHI to really help folks see the value, measure integratedness, demonstrate to payers and others what this might look like. We're in the middle of starting this paper and getting going, and the Bipartisan Policy Center report came out. Because timing couldn't have been better. We had started this like January, February 2021, and so this paper came out, and they really did a whole bunch of our research for us. They really talked about policy barriers, and the paper was about what was stopping the advancement of integrated care, and this is what they recommended as a result of this paper. So it's like almost like they outlined the chief for us. We're very grateful. They said we must define a core set of service elements. What is integrated care? If we're going to pay for it, what are the core things you have to do? Is it screening? Is it measurement-based care? Is it brief interventions? What is it? What is it that you have to do? What are those core services? And then what is a set of standardized quality and performance metrics? How do you demonstrate that your integrated care worked? And then we need to incentivize organizations to do integrated care based on this. So the CCBHCs and you guys have CCBHCs in Arkansas, Patty, right? You guys have that? Yeah. So incentivize them then around these core elements and quality metrics, right? And incentivize Medicaid and Medicare to actually pay based on this, and then develop that core of integrated care measures. So it's like, wow, this was the intent of the chief when we got started, and out came this paper where we were like, yay, we actually have someone else who's done a ton of research, the bipartisan committee, and they really helped us kind of help set the frame for what it is we need to do. This is why we got the reasons why integrated care hasn't worked, and they're saying, if you want it to work, this is what you need. So I'm going to show you what we did, and we probably did a little extra, but this is where we really meshed really nicely. And again, we had no idea this report was coming out. The timing couldn't have been better, so really nice kind of team effort. So I want to talk just for a minute about words. So integrated services in the CHI is bidirectional. And we are used to saying that bidirectional only means primary care and behavioral health. And we want to say that's not what we're saying. We're saying it goes both ways, okay? So the CHI will cover if you're in a behavioral health setting providing primary care, or you're in a primary care setting providing behavioral health. We understand the attention that we must pay to social determinants, And so we're saying that this integration is going on in the setting in which the person is most naturally engaged. So your patients with schizophrenia are going to be most naturally engaged in your community mental health center, in your CCBHC. Okay, so that's how we got at the setting. If you don't have a serious mental illness, you're most likely going in primary care, and that's where you could best receive your mental health services as long as you don't have a serious mental illness. Okay, so that's what we mean by integrated care. First thing we need to do is define it. Integratedness, we love this word because it's not really quite a word, but we made it up. Integratedness is, like the SAMHSA 6 levels was trying to get at integratedness. What level are you, right? So for us, it's the degree to which you are delivering it to individuals and populations. So that's what we're doing. How are you? Because organizations want to know, how can I self-evaluate? How can I look at myself and know where I am? And what we included in this were structural components, like what staff do you have on board? If you're a primary care clinic and you don't have a behavioral health person, it's hard to say you're integrated, right? You don't have even the basics like staffing. The care processes. So what is it you have to do? There has to be screening. There has to be measurement. What are those things you have to do to support what you're saying? I'm at level X. These are the things you have to do that, okay? So that's just some basic terminology as we get into this. We also thought it was important to say what integration is not, because there's a lot of confusion around what integrated care is. States will tell you, in particular, state Medicaid agencies, they'll tell you that they put their behavioral health and primary care funding together. Yay, we're integrated. Well, that's not integrated care. That's integrated funding. That's very nice, but it has nothing to do with what the patient is experiencing in that primary care clinic. They just brought the funding streams together, putting them under the same lines of authority. We redid our org chart, and behavioral health and primary care, yay, they're under Dr. Gibson. That's not integrated care. They're still doing parallel play. They're still not integrated. But people will say we're integrated because we changed our org chart. Co-locating your services in the same building, again, it's not integrated care. You got a hallway with a bunch of white noise machines going and do not disturb signs on the door, and then you got a busy primary care clinic down the other. Again, parallel play. They are not integrated. They are just existing in the same building. And then contracting with a managed care organization. This is happening in Medicaid right now all over the place. The one organization is managing both physical and behavioral health. They're not integrated. They're just managing. When we think about integration, what is happening being experienced at the patient level? So just keep this in mind, that if your state is touting their integration, yeah, we want the funding streams and things to come together, but it's not integrated care. So we thought it was actually important to say what it's not. So what is the CHI? What are the characteristics? This is what we wanted to make sure of. Number one, broad application to the setting, the place where the person's most engaged. It covers adult and children. We had child psychiatrists and pediatricians on our panel. We made sure to do that because we don't want a separate pediatric CHI. The domains that we're going to talk about, these 8 domains, are evidence-based. We have pulled them from evidence over the years, and the work kind of started with Dr. Henry Chung at Montefiore. He was sort of the leader in really trying to break this down and see what the evidence was for it. What's the research out there? There have to be measurable standards, and you can use it as a self-assessment tool. We wanted people to be able to say, where am I and where do I want to go? It's flexible. People are going to have all different kinds of programs. It connects the progress to metrics. I worked on the metrics section. I'm going to show you a little bit of that. And then from that, you can connect payment methodologies. So when we're all said and done, we have recommendations for providers, recommendations for policymakers, and recommendations for payers. Payers, policymakers, and providers, all my Ps. So what are the components? And I'm going to show you in a minute a slide where you can actually download it. What are the components? Number one, there are 8 domains, and these are your care processes, okay? This is what you need to be doing if you want to say you're moving along an integrated spectrum. Here are the exact tasks. Here's some things you need to be doing with some flexibility, of course, recognizing what you could be doing. That's different. From those 8 domains, we developed 3 constructs. We call them integration constructs. So that's the bucket that you're in, okay? You could be in kind of this beginner bucket, this intermediate, or this advanced. you can kind of self-assess yourself along 8 domains and then kind of see which bucket you end up in. It's not rigid like maybe the SAMHSA 6 levels. There's flexibility around it, so you can kind of see, you know, I've got 5 of the 8 domains where I'm kind of in the middle construct bucket. So I'm going to sort of call myself that and work to bring up those other domains. Okay, so there's flexibility in it. It's not a rigid tool. Right now, if you get a grant, SAMHSA says you must place yourself on where you are on the SAMHSA 6 levels today, and you must promise you will be up 2 levels by the time this grant is over. That's how rigid we've gotten with the SAMHSA 6 levels, and it just doesn't work for folks. Then we have metrics and then payment methodology. All that, these are the 4 things that you will find in the CHI. So here are the domains, and again, and I hope these look familiar to you. If you're doing integrated care, these 8 things should be going on in your program. And sometimes they do, and sometimes they don't, in all the stuff that's out there right now. So number 1, screening, referral, and follow-up. Referral and follow-up will always be a part of what we do in medicine. In primary care, there's still going to be referral to behavioral health as needed, but absolutely screening has to go on, and integrated screening. So you're screening for something you don't normally screen for. In primary care, you're screening for behavioral health. In your behavioral health organizations, you're screening mostly for cardiovascular risk, if you think about it, but you're doing that screening. So what is going on in that domain? The other is kind of this prevention and treatment. I'm going to go into that in a little bit more. That one in particular, we're not going to go through all 8. We don't have hours. We've had a 4-hour workshop. We might go through all 8. But prevention and treatment, care coordination, and care management, and under this particular domain, you see things like the collaborative care model and the PCBH model, how do patients self-manage. You got to have a team to do it, quality improvement, of course, and then the linkage with community and social services, because we're quite interested, of course, in the social determinants of health. And then in the kind of newer framework that came out recently from the National Council just for integration into behavioral health, sustainability has to be at the key, because that's where we're all struggling, right? We're trying to start an integrated care program, and we, for the life of us, can't make it sustainable. So sustainability, we added as an 8th domain, just so that we were sure about it. So here's what the CHI looks like. Here's one domain. Here's what the CHI looks like, okay? So along the left axis, remember that integrated screening and referral to care, all right? That was the first one I mentioned. What does the CHI say you need to do? We thought it would be good to put in historical practice, which is what most people are doing that aren't integrated, okay? So a lot of places aren't screening. They're not even screening. So, and then there's domains and subdomains. So here's the screening, and then here's the referral, okay? So we have the 2 different pieces that are listed in the domain name. So historical practice is maybe if a patient says something that they're feeling depressed or sad or they're crying when the PCP walks in the room, we say, oh, maybe you have depression, recognize it, start them on an antidepressant. That's kind of, that's sort of a historical practice. And the other thing is if we refer them to external behavioral health, we say, I think you should go see a behavioral health person, check your insurance and see who's on your panel, good luck. And there's no systematic follow-up. So when the patient comes back, the PCP looks at them and says, oh, I noticed in my note I referred you to behavioral health. Did you go? There's no systematic follow-up. It's just, and we do this all the time in primary care. And in behavioral health, we say to our patients, you need to go get a PCP. I took your blood pressure and it's a little high. We don't actually follow up or connect that person to primary care. The CCBHCs are doing a better job of that. But historically, this is what we've been doing. So we wanted to put that in here. Again, we're progressing to greater integration. The first step in doing this in this particular domain is systematic screening. We are going to give the PHQ-9 to everyone who walks through the door. We're going to weigh every patient in our mental health center who walks through the door, maybe even get their blood pressure. So it's systematic, okay, for those high prevalence conditions. And then under the referral, we're actually going to have some sort of formal agreement. If I'm a mental health center, a formal agreement with a primary care, and these are called care compacts or MOUs, where you talk about how you're going to play nice in the sandbox, okay? This is what I'm going to send you. This is what I'll send you all these records, and I need you to send me back these records. I need you to let me know if the person doesn't show. So now you've actually set up a you set up a service where at least you have this recognition of a partnership, right? And then, so this is like, so integration construct number, kind of moving on out in this care management consultation, you would be doing even more, okay? Not only would you be screening, you'd be doing some education, and you're collecting data around your screening, and you're tracking positive results, okay? So you're doing things like measurement-based care. That's a step now to be more integrated. If you're, for the facilitation of the referrals, you've actually now appointed a staff member to track and follow every one of those referrals to make sure they happen. You sometimes see nurse care managers doing this in some primary care clinics where they have the funding, because who's going to pay for that coordinator to follow and track and see what happened with that patient? And then in this comprehensive, now the most integrated bucket that you can be in, and I'm going to go through these 3 buckets for you here in a minute, where we're really going to now think about, not only are you doing the systematic screening, you've got registries, and you're really tracking all of these screening tools, and really you're risk stratifying them to see how many patients do we have with really high PHQ-9s who are suicidal. You begin to do more fancy analytics around it, okay? So the thing to keep in mind is each of these builds on the other, okay? So if you're doing comprehensive, it means you're also doing screening, enhanced referral, and care management consultation, okay? So these all build on each other. But if you say, I am in this bucket to the far right, I am a comprehensive treatment and population man, the most integrated I can be, you got to make sure you're doing everything else, except for historical practice. Whole goal is to move away from historical practice. So that's one example. Remember, there are 8 domains. This is just number 1. Here is, let's see, number 3, okay? So here's number 3, ongoing care coordination and care management. So this is that monitoring piece. Remember I said there are places that just have no follow-up. There are models of integration where it's one touch and who knows what happened. But we really now want to do clinical monitoring of what actually happened as a result of our integration. So historical practice, we're not quite sure what happened. We're not sure what happened with the referral. We're not sure what happened clinically. So in this screen and enhanced referral construct, the team actually has some way of tracking, again, and navigating and encouraging adherence to care. So and this sort of example of this would be a patient in primary care is screened PHQ-9, they have depression. Okay, the primary care practice does not feel they have the capacity. They're too small. They're a teeny tiny little mom and pop shop, but they're going to refer this patient to behavioral health, and they have a mechanism to actually see, did it happen? Did the appointment occur? And really working with the patient now as a member of the team. A lot of patients get referred. I remember getting referred to me, and they would look at me and say, I don't know why I'm here. It's like you've been referred to a psychiatrist, you waited 3 months, and you don't know why you're here. Now, in the next higher, more integrated, we have what's going on. Well, the team members use measures to guide the care plan. So now we're talking PHQ-9, GAD-7, PCL5, Audit C. We're talking about measurement-based care. Okay, and a team member is assigned to make sure this goes on. So this sounds very much like the collaborative care model, right? Because we are measuring, we have someone assigned, we have that behavioral care manager, we're tracking in a registry, adherence to progress, and actually making changes in the care over time. So in here, we have someone who's assigned to actually track and make sure this is happening. In the PCBH model of integration, a lot of this could happen. There needs to be, some elements around tracking that I think would make that a little stronger. And then when you get over to the comprehensive, the most integrated, what's happening in this is really this continuum of care coordination. And you can imagine how important this would be for our patients with serious mental illness that we're trying to get to primary care. And sometimes this is going to work best when your behavioral health and primary care is under the same roof. It gets a little hard to do this between partner organizations. You can, but to get that registry up and running, to have that you can get the A1Cs and blood pressures and BMIs and whatever else is necessary, lipids, everything you need. It's great if you can get it all under one roof. Not required, but if you think about it along an integrated spectrum, that would really be the holy grail, is getting it all under one roof. So I wanted to just, and again, this whole thing is in the link that you're going to have, but I wanted to give you guys a sense of what this looks like. So now we're telling people, here's exactly what you need to do along an integrated spectrum. So from that come these three integrated constructs, which you've been sort of seeing across the top. And we took the 8 domains and put them into these three, and where are you on these domains, and put them into these three constructs. The goal was for them to be flexible, to help, wherever clinic is at this time. If you're a small rural clinic or a large healthcare organization, the goal was for them to be flexible with some degree of consistency. It wasn't like the SAMHSA 6 levels where there's some just sort of, I've rarely seen a person put themselves, after I interview them with their level, that they're actually on the level that they tell me. But they're based on the domain. So what does it look like? Let me show you. All right, so there are three constructs. Screen and enhanced referral. Now this one looks a little bit like the domain 1, okay, but it's not. So we're talking about something different. Screen and enhanced referral would be the first bucket. Think of these as buckets of integration. The second bucket is this care management and consultation, and the third bucket is that comprehensive treatment. Each of them subsumes the other. You have to be doing construct 1 and 2 to be a 3. You have to be doing construct 1 to be a construct 2. So each of them is building on integratedness. Remember, we want our sites, our clinics need to know how integrated am I, so that I can talk about my values, I can talk to my payers, where am I? So these are the three buckets those 8 domains kind of flow up to, if that makes sense. I hope it makes sense. We worked really hard trying to make it make sense. So here they are. So here's the constructs, and we like the word construct. Wanted to get away from levels. Levels seem like you either got an A or an F on the exam. So we're calling them constructs. So construct 1, that's that first bucket. You're optimizing the screen and the referral process. You don't need a lot of investment. Remember, this is a mom and pop shops. The goal of the CHI was to help everybody, including small organizations. But if you're going to do it in a small organization, here's a way to do it in an evidence-based way. We have an evidence base that shows if you use enhanced referral, people get to their appointments and they get better. So we have based it on evidence-based. So this is really nice for a small practice, a one-person practice, who is trying to figure out what to do. And there is value in construct 1. So before, it seemed like on the SAMHSA 6 levels, if you weren't a 5 or 6, you weren't demonstrating value. What we're saying is, you're in construct 1, and I'm going to show you the measures. You are actually demonstrating value. Construct 2, that's a robust commitment. This is, again, where you see the collaborative care model. And then, again, on construct 3, much more, we do see them in a single organization, although it doesn't have to be. But there's a lot more measures. And, in an FQHC, my gosh, I think they have to report 17 measures every 6 months or a year. Combine that with a mental health center, and all of a sudden you've got a pretty robust system. So those are the constructs. We had to kind of think about organizations or things that might, research that might show us in these 3 buckets kind of what's happened. The P-Care trial that Ben Druff did, care management consultation, you can see collaborative care and CCBHCs under here, the PCBH model. The comprehensive treatment, these were a little bit harder to find. We thought about a few, Montefiores, where Dr. Chung works, so he felt like his ACO fit into that. You really have to do the assessment, and we didn't go out and do the whole assessment of these organizations. We just tried to think about in the models that we know who might fit where. That's just some examples of what you would call yourself. Now, so that's integratedness. That's how you move from left to right. Every one of those constructs has enormous value, but how do we demonstrate that using the CHI? So how do we demonstrate value? It's such that we can actually show measurable improvement. I always say people have all this integration. They talk about everything they do, and they go on. And I just kind of sit in the back of the room and raise my hand and say, how do you know the patient got better? And if I get that moment of that pause where they don't know, We don't do that. We just touch everybody, and that's population health, and we think they all get better. You know, we just do a little brief touch in the exam room in primary care. It's like, well, you can't demonstrate value. There's no measurable improvement, so you really do need to think about what does that look like. And you know, anytime that you're gonna do measurement or quality in your organization, you really pick your population. You can't do everything for everybody. Are we going to do cardiovascular risk in the SMI population? Are we going to do depression and anxiety? So you can't pick everything. Pick something. I always say in primary care, look, depression, anxiety, and substance use are 95% of all mental illness. Pick one or pick two. So have an organization that just picked depression. Great. If they have anxiety too, great. We'll treat that. Pick your population and what you're going to do. You can't. If you're trying to demonstrate value, you're going to be way too busy trying to do everything. I'm going to do pap smears. I'm going to do colonoscopy. I'm going to do all the mammograms in all my patients in CCBHC. It's like, it's really hard to do all that. Pick your population, pick the ones that you're going to do, and then implement those indicators and see what happens. If the outcome metrics aren't turning out the way you want, if your screening level for vitals or getting appropriate labs is low, change up your system. Maybe change your workflow. Add an MA to the team so you can get blood pressures whenever patients walk in. Okay, so when you're demonstrating value, you need to kind of follow these ideas. And so in integration, what we know is going to happen as you do more of these integration tasks that you just saw in the CHI across those 8 domains, as the more that you're doing, the more value that it can potentially demonstrate, and then we can connect payment to it. Okay, this is what the payers have been waiting for, but you've got to demonstrate the value. We do integrated care and get mad because the payers don't pay us. We've kind of left out demonstrating value. We've got to demonstrate value, or we're just not going to get anywhere with the payers. So how do you kind of think about the metrics? When we were doing the CHI, we really wanted to think about a balanced set, right? So how would we think about one or more metrics that might focus on prevention of physical health conditions? Again, this is in your CCBHC or your mental health center, and then in your primary care behavioral health. But then there are these metrics payers are interested in are really those that can apply to both. So how is maybe the primary care clinic looking at follow-up within 7 days of discharge, all-cause readmission? Some of these are things you can do anywhere. We don't tend to do like medication reconciliation. There's things we tend not to do in behavioral health. We need to really think about that. So you want to have a balanced set of metrics and picking that population. Okay, so let's take construct 1. What would those metrics look like? You're going to now, I'm in construct 1. I've decided my organization fits the criteria for construct 1, screening and enhanced referral. And I want, how am I going to demonstrate value? Well, number 1, if you're in a behavioral health setting, what's your screening rate for cardiovascular disease? We have a nice ADA, APA guideline. It's been out there since, 2004, I think that came out when the second generation antipsychotics, we noticed people were gaining weight. And, we've known since the paper that came out in 2006, our patients are dying of cardiovascular disease. So what a great way to demonstrate value is in our mental health center. We're getting blood pressure, BMI, cholesterol, lipids, and assessing people for smoking. Great. What would those screening rates look like? And then to demonstrate that you have at least one care compact, that you have set up an MOU with an FQHC or another, let's say you're a child psychiatry or child program, you set up an MOU with a pediatric practice, okay? These are things that we know from research bring value. We know more people get connected to care. We know people get better. That's screening rates. That's what the PCare study showed. So we're using the evidence base to say construct 1 brings value. Construct 1 is not an F. In the SAMHSA 6 levels, level 1 is an F. People have really gotten it in their mind in a way that I think is a little twisted. But we have value in construct 1, and here's how we're going to demonstrate it. And then in the physical health setting, again, screening rates for depression, demonstrating that you've got a care compact with a behavioral health provider. We don't feel comfortable treating all this depression, but we got this great relationship. And then you could look at the percent of people who actually completed the referral. Remember, you had something in place where someone was tracking and to see if the patient, no-showed, never called, couldn't afford it, whatever that is. So construct one is incredibly valuable. Now we're going to show it, and we're going to bring these numbers to a payer if we need to, or say to the payers, this is what we're going to do. Please pay us a case rate so we can actually afford the staff we need, the MA we need to get these, to do the screening for cardiovascular risk, the care coordinator or navigator we need to make sure that these referrals are getting where they're supposed to go. So that's just an example of a metric for construct one. How about construct two? Let's say you're in that middle bucket. Number one, everything that was in construct one, you could use as a quality metric. You could show that to a payer. But now we're going to up the ante. So in behavioral health settings, who did we offer nutritional? How many kids did we with a high BMI did we offer nutritional counseling? What's the percent? Okay, that's a value metric. Of the people with opioid use disorder, what were our retention? What were our retention rates at 12, 6, 12, and 18 months? That's become a really nice metric for really understanding how long patients are staying in opioid treatment, because we're realizing if they stay in less, their relapse potential is extremely high. And then what about glucose control for the SCMI with diabetes? So the A1C less than 9 is a HEDIS metric. All of a sudden, we are demonstrating value in what we're doing in integrated. We know where we are in integratedness. We're in construct 2. Here's the value we are bringing because of our integration. In the physical health, in my primary care setting, we're talking about percent reduction in PHQ-9. 50% is a clinically significant reduction. How many reached remission? Remission of depression symptoms in primary care, that hit the FQHCs this year. And if they're not in construct 2, there's no way they're going to meet that criteria that is now part of their metric set. They actually have to demonstrate to HRSA. So if you're not in so these are construct 2. Now you can see how we've upped the ante. We are now talking about changes. We're talking about direct clinical interventions. And now, are your patients doing this? Because if you're in construct 2 and you're doing it well, and again, this is just a list of examples. I told you before, in your organization, think about what your population is, look at the potential metrics, and you come up with your own metrics. This is just a sample of what it could look like based on how you designed your integration program. Now we have hardcore metrics that we can demonstrate value in our integration, depending on which domains we're in, where we are in those domains. And again, it's kind of funny how you may be at a different level in domain 1 than you are in domain 2. We haven't quite figured out, if you count them all up, how do you figure out which final bucket you're in? Like you have to have 5 of 8 or 6 of 8 to be in 2. We haven't quite got that all figured out yet. We'll get there. But this just gives you some idea about what this could look like. And then I think I might have done one for 3. Here we go. Now we get into the big stuff. And the payers tend to be right here all the time. Show me the ROI of your program. But so in both of these settings, not only are you doing metrics, you also have metrics from construct 1 and 2 that I just showed you, but you're also now demonstrating this. You're really looking at the larger, longer, these metrics that take a little longer to get to. But now you're looking at reduction in ED utilization, inpatient hospitalization. You're looking at follow-up. Now you're into these big guns that really can impact cost of care. So this just gives you a sense. And again, these are examples. Your organization can pick the ones that they think demonstrates value based on what they're doing. Maybe you're doing an expert program, and what you need demonstrated how many patients had reduction in alcohol use below the NIAAA safe drinking limits, how many reached abstinence, how many were put on MAT for substance use, right? There's all kinds of stuff you could pick based on the population that you have. These are just examples. So in the CHI, we have a bunch of examples for you, and the payers love that. We had payers that were on our panel for sure. So here now, next step. Remember, integration, integratedness, value, payment. We have, again, have not connected these 3 for the payers, and it's not getting paid for integrated care, that's really been, I think, a major stumbling block. And if that's happened in Arkansas, then I would guess you're like the rest of the country. Either the policy gets in the way, you can't do same-day appointments for behavioral health and primary care, or, well, there's just, we're not going to pay you for it anyway because we haven't seen the value yet. So how would you match the payment, all right, for screening for construct one? Now I'm in bucket one and I need some payment. Okay, well, we've always talked a lot about just small grants to get you started. A lot of these organizations, CCBHC, you get extra money. A lot of the collaborative care, we've been providing startup grants. So people are always looking for grants to get started. It's really hard for a clinic to start de novo with no funding for startup costs. A CPT code that would really help us. We could build a CPT code if you're doing enhanced referral correctly, if you're doing X amount of screening. Also, what would that value-based incentive payment be for the screening and referral? So what we're saying to payers, go back to that bipartisan report. That was one of the things that was missing. So we are giving in the CHI recommendations to payers, and you can use this in Arkansas with Medicaid or your private payers. Here's some things, if you would give us one of these three or something else you cleverly come up with, it would really help us be in construct one. Otherwise, we're going to stay in historical practice forever because we can't afford the staff it would take or the time it would take to really do construct one well. So that was for construct one. For construct two, again, implementation grants, the bundled care enhancement payments. We have that for collaborative care. We're so lucky. But we got it because we demonstrated value with collaborative care. That's how we ended up with 4 CPT codes and now a 5th for collaborative care. But what would a bundled payment look like to cover those costs? Remember those brief interventions that are too brief to bill, or heck, you can't do them in same-day billing anyway, or you had a hallway conversation with the PCP or a hallway conversation with the behavioral health person. All those things, I always say what works isn't billable. All those brief team things that are going on aren't billable. But if you gave me a bundled payment, now all of a sudden the psychiatrist and the behavioral care manager can meet for an hour and review the registry. We can have team meetings. We can talk in the hall. We can do all kinds of things, which is what happened with the collaborative care bundle. We need this for other, especially that care of the SMI patient. We need nurse care managers in our CCBHCs. We need folks that are really helping us with care management and consultation. So again, we're matching the integratedness to the value we're going to produce and now asking for a payment structure for that. And in 3, again, the enhanced payments can certainly help, or risk-based capitation. So we're now talking about value-based payment mechanisms in those larger ones. We'll do shared savings. We'll share that with you. We'll give you a performance bonus. You can go totally at risk for the care. A lot of organizations are saying, bring it on, just put me at risk. And they're going to do whatever services are evidence-based. They can go to the CHI and say, I want to do full risk. Here's what the CHI says. Here's the CHI says, I need to do all of these things if I want to expect that I'm going to get value. So they now have a tool they can go and look at and go, all right, this is what I need to do. We got it all laid out, 8 domains that are moving to the right in terms of your level of the tasks that and outcomes you need to be thinking about if you want to be incredibly successful. And then at the end of the paper, we had recommendations for providers, for payers, for policymakers. So for the providers, we're saying use the CHI. Look at the care processes. We've given you 8 domains that are evidence-based. We've given you across the spectrum. Here, as you move towards more integratedness, here are the things that you literally need to be doing. We're literally saying, here are those processes that are at 30 years of doing integration. We know that care management in a mental health setting, that someone who is tracking and following and working your care coordinators in your CCBHC programs, in your patient-centered medical homes, they require care coordinators, care managers, that those folks working with, especially your SMI population, will increase the number of primary care visits they get, the number of times they get their blood drawn. It will help their A1C be reduced. We're now giving you exactly what you need to do in order to, this tool tells you what you need to do. And so use it. Part of the recommendation to providers is use it. Don't use the iPad. Don't use some of these other things that we aren't sure if they bring value or not. They were never based, we didn't have enough knowledge about it. When the 4-quadrant model came out, I think Kathy Reynolds or someone said, it seems to make sense. This is where you get your care. But we didn't have value and payment connected to that. We were just trying to figure it out. When Doherty's 3-5 levels came out in 1996, Dr. Doherty was just trying to figure out where to place and put and figure this out. But now we have a very sophisticated tool. So for providers, use it. Let it help you move along the integratedness spectrum in an evidence-based way. For payers, here is a way to connect payment now for the first time to the value that integration is bringing. Construct 1, Construct 2, Construct 3, or in the actual care processes that are going on. And then for policymakers to really think about, where are those impediments? Where are we getting in the way? So we have some very specific recommendations to policymakers to reduce these barriers. Don't get stuck in, I can't hand off a patient for a primary care appointment. I can't hand that person off to a BHC because we don't reimburse behavioral. We don't allow same-day visits, or we have a carve-out, right? Behavioral health is carved out, and we're getting hung up with, well, they can't see your social worker in the clinic because behavioral health is carved out. That is a huge issue in a number of states. So patient has to come later. Well, we know when patients come later, next day, next week, that there's a high no-show rate, there's stigma and cost and all kinds of stuff. So we know that hasn't worked very well. So we're saying to policymakers, get rid of these artificial barriers. I just think they're just really artificial barriers that are really making this hard on everybody. So that at the end of the chi, a policymaker, a payer, you can go to the end of the chi, because people are going to read the part that's relevant to them. Go to the end. We actually have a hyperlink built in. If you're a policymaker, just go straight down, and we'll give you the recommendations that we think will make this different. Here's the whole report. It's available for download, has been for about 3 or 4 months now. I encourage you to, or maybe you may have already sent this out, Jenny, I'm not sure, but download the whole thing. And now you've got the all 8 domains, everything you need to do. It's a lot of pages, but that's okay. You would expect it to be, especially after I worked on it for over a year. There's going to be a lot of pages in there. But download it and see for yourself what's in there, what you think, and how in Arkansas you can use it. Okay, and that's the definition of chi. We had so much fun with this when we were developing the developing the tool, and we're finding people are using that as their shortcut. It's like the 6 levels, 4-quadrant. Well, now we're the chi. So anyway, we have about 5 minutes, and if people, and there's a couple things that have been said about CCBHCs in the chat box. If there are other questions, people can just unmute. We're kind of friendly audience here. If people have questions in our last 5 or 6 minutes, things they want to talk about. How do you think you guys are going to use this in your integration program?
Lori, this is really helpful. We've had up to 60 people on the line, and I don't even know everybody, but I know that there's a good mix of, there's clinicians or providers here, there are payers here, and we have people from policy. And so we definitely want conversation now or in the chat. Dr. Raney is an expert on this, and it's exciting to see you bring together how to actually do it if you're a clinician, but then how to measure it. This whole metrics thing has been a mystery, and then how to make that make sense to payers. At times, clinicians, we kind of make the payers be the bad guys, but they're just trying to take care of their patients too. So it's good to be able to make the connection of all 3. Anybody else have any questions or comments?
I know it's a lot of stuff. And again, there's hyperlinks in it to help you go to the section so that you don't have to read the whole thing. Go to the hyperlinks and go straight to the metrics, Patty, and look at that section and kind of see what it looks like. The entire framework is in the back. All the references, if people are like, where did they pull this, we get this stuff from, all the references for everything from enhanced referral, everything's in there. So we tried to be extremely thorough. So if people have questions around this, and people may need to digest it a little bit, you are, certainly welcome to shoot me an email if you have any, further questions about it. But,
If I can,
Arkansas, yeah, go ahead.
I just wanted to introduce myself. My name's Tucker Martin. I'm the Chief Operating Officer for River Valley Medical Wellness. I work for Dr. Kristen Martin, double board certified as an addictionologist and a doctor of osteopathic medicine. She apologizes she couldn't be on the call because she's at a conference in Branson and wanted me to set in. But thank you for a wonderfully informative presentation. I wanted to know if you could speak more about the bundled care enhancement payments when we're talking about integration construct 2.
Yeah, and that's what we've seen with patient-centered medical homes. It's what we see with the collaborative care model of integrated care. So Patty, where are you guys with collaborative care? Does Arkansas have them turned on for Medicaid?
Well, we have a new Arkansas Medicaid committee for BHI that actually has met this week, and we had conversation in that meeting this week. And I want to celebrate those who were in this call today, but we are asking for those codes to get turned on. We do know that there are multiple groups in the state who are trying to do collaborative care management, and some are submitting codes to Medicare and commercial payers for COCM. But
so Tucker, to your question, the collaborative care, if you're in a primary care setting, the collaborative care codes is a bundled, it's this care enhancement bundle, and in that bundle, the patient gets screened, the patient gets brief psychotherapy, the patient gets psychiatric consultation, the patient gets tracked and referred as needed. So it's a bundled payment because each of those individual tasks, some of them weren't even billable. Sitting down and reviewing the registry with the psychiatric consultant's not a billable service. So that it's a bundle for those services. The other thing is patient-centered medical home. And I don't know, again, in Arkansas, if you guys have done it in both primary care and behavioral health, but if you've done it in your community mental health centers, guys don't have PCMH, they were paying a bundled rate for the care coordination and the services. So it might have been $325 a month. Whatever that bundled rate was in Arkansas, they were giving you that care enhancement bundle so that you could provide those services that a nurse care manager tracking and following and working with a patient may not be billable in a community mental health center, for example, or it's carved out or whatever. So those care enhancement bundles let you provide a bundle of stuff that, some of it might have been billable, but a lot of it wasn't. So you can now provide all of it, and we're going to pay you $325 a month or $145. You bill at the end of the month for that bundle that you provided. So for a lot of things, that can be very helpful if there's an evidence-based model that you're following that we know brings value. So I'm going to give you one payment, bill me on the last day of the month, and this is what I expect you to do. And for the collaborative care, there's a list of 10 things they expect you to do. Monthly PHQ-9, a monthly case review, a monthly brief interventions, this whole list of things they expect you to do as part of that bundle. Does that help, Tucker?
Yes, it does. And light bulbs went off in my head when you were describing that process, because those interactions are what happen literally in the hallways of our clinics every single day. So thank you for that information.
And Tucker, I always say what works can't be billed. All those things are just so important, but so what works can't be billed. You try to bill for that PHQ-9 you gave and the 96127, maybe you get $10, maybe you can only bill it once a year, maybe you can bill it twice a year. Well, I need to give it once a month. And if I don't have a code that lets me out, I can't do what works. Measurement-based care works, and yet I can't get reimbursed for it because of the structure we have right now with payment around, administering something as simple as a PHQ-9 or a Vanderbilt.
Right.
That's a
And
great question.
those are the things that frustrate our providers on a daily basis.
Yep. Absolutely. So if we can get a bundle around that, if you can get collaborative care paid by Medicaid and your private insurers, or you can get patient-centered medical home rates continued after, the federal money runs out for patient-centered medical home, and then all of a sudden your programs run out and people have to let that staff go and not do that evidence-based practice. So it needs to be really baked into your system.
Right. Right. Thank you very much for answering my question.
Oh,
I know we're at time. And
yes.
if folks have other questions, they can shoot them to us later.
Thank you, Dr. Raney. I know we are at time. I want to thank everyone for your attendance today and for your questions. Dr. Raney, I know that this is fairly new to us. As you said, it's been only out about 4 months, and we have been studying this and looking at these 8 different sub constructs. And so thank you for coming here, for explaining this to us, and really for validating integrated behavioral health. This is complex. There's a lot of different pieces. As you say, over 30 years, we've been trying to get some movement. And so we're really excited. I do want to recognize in Arkansas, there's a lot of work right now happening around trying to move integrated behavioral health forward. I think that all levels are starting to really identify the need and work together. We have policymakers, we have payers, we have providers who are all talking, trying to brainstorm. So we're definitely going to use this and use these different pieces to help carry us forward. Dr. Gibson, would you like to close us out?
Just want to say thanks again to Dr. Raney and to everybody for attending. And the links will take you to the website. There are some recordings there on the CHI, and we hope to continue the conversation here in Arkansas and then connecting with other people around the country who are using it. But this is excellent presentation and an exciting framework.
Yep. I'd love to hear how it works for you to use it, because now all of us have devoted such a chunk of our lives to it. We want, okay, what's now the clinical experience? So feed us your stories. We'd be we're interested to hear, how did this work in Arkansas? Every state is going to be different. Everyone has different policies and different payers. So thank you guys. Have a great day.
Thank
Thank
you.
you.